I want you to start by just imagining a patient of mine. A 70-year-old guy lives by himself up in a cabin in the woods up by Lake Wenatchee, and one night develops crushing chest pain. And so he calls 911, paramedics come get him, run him down to Wenatchee, the emergency personnel stabilize him, they get him onto the cardiology service. They run him back to the cath lab, they diagnose a critical stenosis. They can't get a stent in, so this guy needs a bypass surgery. So the preoperative crew, the anesthesiology crew, the cardiothoracic team, they all get together, get this guy into the OR, crack his chest, bypass the blockage, and save his life. And that's an awesome thing. And nobody would deny this gentleman those services, and I guarantee when the surgeon asks for the scalpel, nobody's asking him for a prior authorization. So, for the sake of the discussion today, I Googled it. In 2015 dollars, a bypass surgery cost between $70,000 and $200,000. And that's just a surgery, it's not stuff that comes before and after. And keep in mind that what you've done during that surgery is you bypassed a 1 centimeter segment of diseased artery. The rest of this patient's vascular system remains diseased. And all of the risk factors that led to him being there in the first place have not been addressed. And I guarantee you this guy will be back, whether it's a stroke or ischemic peripheral vascular disease, another heart attack or kidney failure. This guy is now one of the 20% of our patients that utilize 80% of our healthcare resources. And you look it through the eyes of a rural family doc, you got to think it could have been different. Okay, so let's look at this guy again. So he's 70, he lives by himself up in a cabin. I can almost guarantee you this guy's a character. Right? These are like my favorite patients. This guy brings you like a cooler full of elk meat when he comes in to see you. He's always got like an off-color joke or harasses about your politics. Love taking care of these guys when you can get them in. So what I've got to take care of this guy is about 20 minutes every 3 months. And if you think about recent data that was published, it says that every hour that a primary care doc has in face-to-face contact with a patient, they have 2 hours of administrative work or paperwork to do. That 20 minutes is actually 7 minutes. Unless, like most of us, you go ahead and use the whole 20 minutes and push the rest of it back to when your family's having dinner or after your kids get out of bed. And to help me out, I've got one nurse. And trust me, she works through lunch and stays late too. Now what I don't have is reliable access to a psychologist, to an addiction specialist, to a behavioral health medicine, a pharmacist, or any other allied personnel. So if you think about this guy, he, at this age, probably is a Vietnam vet, and PTSD probably influenced how his life played out. Good chance he's got some residual depression and anxiety, and they're kind of hard to tease out and pretty hard to treat in this population. Good chance he's a smoker. Hard to say, might even smoke a little weed. Alcohol might play a role. His social network is probably fairly thin, living by himself in a cabin. So as far as people to come by and check on him, finances might be thin, so transportation, especially when the snow flies, housing, getting in and see the doctor, affording good food, paying for their medicine. And for these and other reasons, taking care of things like depression, diabetes, cholesterol, and all of those primary care issues are really tough. And the point I'm trying to make is that caring for these folks requires every bit as much expertise, just as much teamwork, and just as many resources as it does taking form when those end-stage complications arise. And that's the part that I don't think that we have really fully committed ourselves to. All right? If you wonder why in this country we spend twice as much per capita relative to other industrialized nations and have the lowest markers in terms of things like preventable death and other important healthcare outcomes, I think it's because we haven't invested in our primary care system. I don't have the numbers specific to Washington State, but in general in this country, we're about 5% that goes to primary care, $1 out of 20. All right, and those systems in both private and public networks that have intentionally invested more, that have brought that number up to twice that amount, those are the ones that are accomplishing the triple aim. And I appreciated hearing that we're really shooting for the quadruple aim. If you invest more in the medical students that want to go into primary care, and then you support those primary care physicians with the staff, with the healthcare infrastructure, with the allied personnel, all those talented people that can help us take care of people, when you get those systems in place, suddenly you got better systems of care, better health outcomes, and you save money everywhere else. You have much lower costs, and you have more satisfied providers. So I could talk a lot more. I think I'm already overstepping my time. I hope we have time in the Q&A to get into more detail. Thanks so much.
Good morning, everyone. My name is Ralph Barrett, and I'm President and CEO of Carina. So Carina, for those of you who don't know, is a virtual healthcare company. We build and operate virtual clinics for hospital systems. We partner with hospital systems and healthcare organizations to operate a clinic under their brand. What is a virtual clinic? A virtual clinic is a way that a patient can request and receive care 24/7 by a phone, by a webcam. They can get connected with a primary care provider. We call them virtualists, and they can get their initial questions answered. In the United States, healthcare is sort of dominated by what I call the 3 H's. I hope it's not serious, I hope I can see my doctor, and I hope it's paid for. And so what we focus on in the virtual clinic is getting patients that information. Is it serious? And can I see that doctor? Getting those 2 things taken care of right away. With regard to payment, well, there are some challenges that even technology can't overcome. I'm just being facetious there. I love to rib my friends on the payment side. Just to give you an idea of the amount of work that we're involved in, Carina has created, in collaboration with the Washington healthcare system, a very interesting virtual laboratory here in the Puget Sound. Carina has partnered with UW Medicine, with Virginia Mason, with CHI Franciscan to deliver care in these urban centers. We have partnered with rural providers and work with the Washington State Health Authority, WSHA, the organization, to provide services to rural hospitals. And we are partnered with Skagit in Mount Vernon, with Mason General, with Kittitas, and with Summit Pacific. We serve the patient populations of Microsoft and the patient populations of Boeing, and we also serve a 650,000 Medicaid patient population through a partnership with Molina, working to extend primary care in rural and remote areas. So if you consider what we've done, and then you look at what's happening with group health, and you look at what's happening with Swedish Providence, Seattle and the outlying communities are the most wired, big surprise, healthcare delivery system in the United States. It's a very interesting virtual lab. So obviously, our view of technology and our view of the challenges are, what are the opportunities to use technology to extend those services that patients would know and trust? So how can we use technology to make available additional capabilities to patients rurally and in urban centers? Rurally, we think of the problem as threefold. First, access. How do I get to see somebody? That patient Tony described in the cabin, they probably have a phone, they probably have an internet connection, they might have started that care journey online. Now obviously, someone with crushing pain is not going to get cared for in a virtual visit, so that's not a good example. But so many people are going to avail themselves of an emergency room or request an appointment of their doctor for something that could have been managed virtually and could have been managed remotely, reducing the load on that provider's team. The second thing we can use technology for is to deliver expertise into remote areas or into rural areas that wouldn't have access to those specialties because there's not enough visit activity in that area. So rather than just having someone be available through a circulating staffing model, could we make that person available on demand through telemedicine and a provider-to-provider conversation? We've seen that with telestroke, we're seeing that with other specialties, and we think that's some huge opportunities there. And then lastly, can we use technology to change how we staff? The virtual clinic, it's very easy for a provider to enter the virtual clinic and go on duty. They simply log into a website and they are now connected with the patient activity in that virtual clinic. So it's possible now for organizations like Carina and other folks in the telemedicine space to augment and supplement those teams and work in side by side with folks working in rural locations, so that when it's 11 o'clock at night and there's only one person on duty in the hospital, there can be people available through telemedicine technology and or directly to the patient through a virtual offering that's provided by a hospital system in their market. So we are very optimistic about the opportunities for technology. We think we've got a very interesting lab, and I look in the room here and see lots of friends who are involved in collaboration here, and I look forward to the rest of this conversation. So let's turn now our attention to this afternoon, or this morning rather. I've been traveling too much. Morning, afternoon, I don't know. So On this sheet here, call your attention to some work that we've been working on here in the Rural Collaborative. And Tony and I are going to pass back and forth. But on the front, we outlined some scenarios here facing some of the challenges facing us. On the back, a summary of some of the reality. But we wanted to get us going with some of the discussion questions in our session here today and see if we couldn't come up with some answers. Do we believe that funding innovation can balance inequality? Are there technologies or other innovations, not just technically enabled, that would improve things? Can we demonstrate leadership in our state, and how do we want to serve as a beacon for the national and international problems? And are there alternative funding mechanisms to demonstrate viability in an initial targeted community? And then lastly, do we believe we should demonstrate initiatives in the next 2 years? If so, where and how? So what we hope in the next few minutes is to get some conversations going. Obviously, Tony and I are here to answer questions, but we really want to facilitate a conversation here and try and address these as a group. And then we'll try and wrap up a kind of consensus at the end, if we do have one, and so we can take it to our colleagues that participated in other sessions. So Gary's going to come up and join us, and we have a mic here so that we can make it easy, and then Tony and I are going to share this one. So are there any questions that someone has to get us started this morning? If you can hear Tony and I, we won't bother to pass the mic. Is that okay?
Thank you. I'm Jack Davies with the Northwest Rural Health Network, and this is more of an observation than a question. But the issue with innovation and with technology, including telehealth technology, is that quite often it is presented as a solution, typically from an academic medical center, that is a brand. It's presented as a solution that's brought to a rural community and said, here, we've got your answer. And the challenge is that the rural communities really need to be the drivers, and they need to be the ones identifying really what the problem is, and then understanding and adapting the technical solutions. And so it's just so important as we talk about innovation, as we talk about funding models, that all of those are driven specifically by the rural health systems and how they work, and of course they all work differently, how they work and what their needs are in that particular community. So there's plenty of opportunity to do that, but I just want to emphasize how important it is to start at the local level and then work out rather than vice versa.
Yeah, I mean, I'll comment on that. Our experience working with hospital systems in Washington State and across the country is you've seen one hospital system, you've seen one hospital system. And the challenge is the mix of the patient population, the demographics, the unique set of employers, et cetera, create a dynamic that needs to be addressed locally. And I couldn't agree with you more. And that's why our strategy has always been to partner with local organizations, because they understand their problem, they understand their patient, and provide capability through that. I think technology presents the opportunity for additional collaboration, but you can't export solutions from other places. You need to have an on-the-ground part of the solution. I couldn't agree more. But I think we should reflect that in our comments here, that any strategy that this group would put forth needs to have a home component, not an import expertise from someplace else.
And not to reiterate, but I would forcefully echo that. I know every community is in a different place as far as their infrastructure in terms of what their needs are. And it's nice to know what your options are. It's nice to know what is available out there in terms of training, in terms of these kinds of technology. But then you have to, at a local level, decide where you are. And the next thing you might need be new blood pressure cuffs, not telemedicine. It's hard to say. So, but yeah, you have to work from the inside out, not outside. Thank you for that one.
It's interesting. There's a rush. I'll echo a concern that I have about technology, and I'm the tech guy in the room. Is that there's a hurry to use things when really someone needs to see somebody. Our data suggests that clinically it's appropriate about 68% of the time for a patient who is otherwise unguided to be treated virtually. That means 32% of the time they need local resources. And so any solution that is imported into their market better be connected into the local market, because that patient is going to need that. And at a minimum, even if they were treated virtually, they're going to need follow-up. And as Tony outlined, we cured the crisis, we bypassed, but we haven't fixed the problem.
Mark Stensauger, I'm on the Rural Accelerator Committee. It seems to me that telemedicine is advancing rapidly in the integrated delivery system. Kaiser in particular has huge examples of major gains in this area. As you look to the rural delivery in Washington State, where you have individual hospitals scattered around the state, is there the opportunity to develop some kind of integrated platform rather than working with each and every hospital? Can the rural community come together? It looks like the large systems are not reaching out that much to the rural communities right now. It looks like this may have to be self-actualized. Is that possible?
You know, that's a great question. So we started working, with Mason General, Skagit, Kittitas, through WSHA, who were thinking about this at the outset, and they came to us and said, hey, we're going to try and solve this problem for all of our hospitals in the rural setting. Those organizations in Oregon, in fact, through OAHHS, a very easy acronym to pronounce, in Oregon, there's a collaborative funding, the same thing, where they're looking to standardize the kind of offering through each system. There are two considerations that are a challenge. One is, what is the brand, what is the name that the patient knows and trusts? And you don't want to use technology to disrupt that brand or that their trusted relationship. You want to use that to extend that. And then the second thing is the electronic patient medical record. Again, being a tech guy, there's a lot of wonderful things that come from EMRs, but they are absorbing so much funding that could be used to create networks and sharing resources so that we can use technology to make a resource in one rural facility available to a resource in another rural facility, so that in aggregate they would be able to work together to create some problems. Those are standards in communication, those are standards in service offerings, those aren't necessarily standards in electronic medical records. The medical record is a record of what happened. It isn't very good at facilitating what is happening right now. So I do think there are opportunities. We haven't seen anything. I mean, WSHA has probably, they came to us first, so I think they've been aggressive, and I'll give them lots of props. Oregon is the next one that's been moving that we've seen, but the Pacific Northwest, I think, is leading the charge right now.
And I might tag on to that just a little bit in terms of what it takes in a small town to get something like telemedicine going. Obviously, there's technological issues there, but I think those are actually surmountable. You would need some probably outside sources of funding. You need some people with the bandwidth to even think about it. I think that's one thing that's often forgotten is that doctors are just trying to take care of the patient and get home. So is everybody else in that clinic. We don't have other people sitting around to take this kind of stuff on. And that's, we have in our facility, for instance, inpatient side, I've got a social worker that can help with placement. We can't bill for her services. She's not available to us. One day a week, we've had a psychologist who's worked with us. We'd rather get somebody who's available more routinely for warm handoffs and stuff. I just heard the two main insurers, I just got an email 3 days ago, two main insurers are no longer paying for his services, so it's easily going to go out of state. So we just lost our psychologist. So if I had somebody local that could take a patient from me, coordinate with a telemedicine program to help with diagnoses, and then coordinate it back with local resources, that would work. But I don't have the infrastructure to do this personnel or technology right now.
I'll tag on to Tony's comment. When we're looking at technology these days, the telemedicine, it tracks me up when we use telemedicine. Because no one in here does telebusiness, and no one in here does teleaccounting, and no one doesn't. I mean, you just use the appropriate technology for the task at hand. So the observation here is, can we use technology for the task at hand? One of the tasks at hand that is hard when you have to deal with a facility is the ability to use technology to create care teams, instant care teams. So we start that care team with the patient talking to the provider, but that provider needs help. There's no reason why the technology can't bring another provider into that conversation. You don't have to walk across the hall, you don't have to go to another building, you can bring those two together. So the idea of care teams, as we look at the formation of care teams, and that care team doesn't have to be located in the same place. That care team can be located in different places. The sense of place, the notion of place is created with the technology, putting the people in the same place. Now, obviously, this requires that whatever the providers are doing doesn't actually require a patient to be touched, because you can't do that with the technology, although there are technologies come that will gather patient information. But as we think about using technology, let's not think about just doctor to doctor or doctor to patient. Let's think about doctor to patient, or multi-doctor to multi-patient, or one doctor to multi-patients. The things that we can do with technology, the things that we're doing naturally with social, that we can use them appropriately, if we're careful and we're intelligent to address some of the shortcomings. But not a panacea, but some different ideas in terms of technology.
Hi, Doug Conrad from the University of Washington. We are evaluating the state innovation model, and Healthier Washington is part of it. And one of the things, I want to give a shout out to Gary Swan and Roger Gantz and the State Hospital Association for the good work that they're doing in this area and educating us as evaluators about what's going on. But my question is this, and it kind of tags on Mark Stensacker's question. I noticed that one of the discussion questions says that we believe that funding innovation can balance the inequality. And it occurs to me that with the efforts of a public hospital district, the critical access hospitals, the rural health clinics, and the federally qualified health centers, that the efforts to try and change reimbursement to those two faces a couple of key challenges. And I wonder if there are any solutions in the room or interim solutions. One is the level of funding. As I've listened in to the Critical Access Hospital Advisory Committee and APM4 committee that's looking at the FQHCs and the RHCs, there's a lot of concern about financial viability of the institutions, level of payment being helpful with that respect, but then it's the mode of payment. And I wonder if there's a creative solution that would bring together the providers on the ambulatory side, providers on the inpatient side, and these occupancy rates in the critical access hospitals are very low, they're very small. Is there a way to bring them together into a virtual plus real physical integrated delivery system so that we could think about funding innovation as an integrated whole rather than we'll deal with the FQHCs and the RHCs with a sort of a shadow primary care capitation model, I might call it, and the critical access hospitals with some changes along the lines of what Harold Miller and the State Hospital Association. Are we getting any closer to an integrated view of this, or do we have to just take the pieces and work with them as we can? We're all trying to be practical people here, including the evaluators. So I'm curious about thoughts from you and any people in the room if we can address that.
Department of Health is at that table too. I'm Pat Justice, I'm the Director of the State Office of Rural Health. And it's part solution and I guess part thoughts about that. I'm really concerned about, we have to get Medicare at the table in the payment change because it's the tipping point in rural. It's the major payer in most but not all communities. The second piece is I'm convinced that the hospitals that you mentioned are hospitals that are actually doing pretty well. We have some really small remote clinics and hospitals that they have much less bandwidth in those organizations. And I keep looking at that shaky bridge model between value and encounter, and I'm convinced I know we need to keep costs down, be budget neutral, all of those things, totally aware of that. But I think they are going to need a small subsidy of some kind to build the infrastructure to cross the bridge. I just don't see how, in many of these situations, and many of the people in the room know it, you've got a person doing 3 jobs, not 1. And so if they take 5 minutes to think about something, they're leaving 3 jobs alone, not just 1. And many of particularly in the clinics, the electronic health records were less expensive than Epic, but that also means that they don't produce population reports reliably, that the vendor soaks them every chance they get. Sort of, you want us to develop a new query, that'll cost this. So there's just this whole bump that they need help over. And I think we have to acknowledge that somehow and think about how, I don't think throwing them practice, I've led medical home collaboratives and we did practice coaching and education. They know what they need to do. They just really need help to have the time, and I think it's a temporary subsidy, but I'm really starting to think without that, how can they do it? So Medicare and some acknowledgement that there's an infrastructure that takes time to put in place to swing with the new paradigm. So those are my thoughts.
I'm going to jump in here, and it's okay. It's kind of nice to stand up here. I don't usually get that opportunity. It's kind of cool. So I think that when you look at something like Medicare and MACRA and medicine ATMs and all that stuff, first of all, the average rural physician doesn't. They just don't. They just don't. And that's not a knock against them. They just are not looking at where to put that level because they're just, like I said, trying to get home at the end of the day. I assume most rural administrators know these things, but how it applies to them, like you said, is extremely tricky. You look at something like macro-MIPS and APMs, no rural clinic qualifies for an APM. Let's start with that. Okay, the MIPS branch is budget neutral, so for everybody that wins, somebody loses. And the losers are going to be the people, not that aren't taking good care of people, but that aren't documenting that they're taking good care of people. To do that, you need extra facilities, extra technology, extra people collecting that data, and it's the small clinics, like you said, that don't have the technological infrastructure, don't have the personnel to do that. So the folks that are behind now are going to get further behind that here. And we talk about kind of this change fatigue that you're hearing from providers. That's a big part of it. I think they just feel there's a disconnect between what's being asked of them and the resources that are being provided to them to allow it to happen. And I didn't think make this case forceful enough, so I'm going to do it now. You've heard me say that for every hour we spend face-to-face contact, we have over 2 hours of administrative work and paperwork. Please bear that in mind. No matter how well-intentioned, do not add to the button clicks, the forms we have to fill out, the things we have to measure, the policy we have to put in place, or anything else that takes us away from our patients, or frankly our families.
Yeah, I think that the challenge, what you're talking about is the small n problem. If we look at what is technology really good at, it's good at aggregation, disintermediation, and distribution, right? So the best examples of distribution and disintermediation are Amazon right here in Washington, right? But the idea of aggregation, unfortunately, we've seen it recently in the political realm where we can bring together and create populations that are vastly distributed. You can do the same thing to change the end, to change the resources that are available to the end. So I will not comment on the clinical challenges. I mean, they are real. The question is technology possible to change the end so that we can aggregate those things where possible so that we can achieve some economies of scale? I just don't know. I mean, as a software person, as a technology person, all my career, I can't look at unconscious and think what's happening. It's actually remarkable. You think that we're spending money for we're a primary care biased organization at our roots. Our view is more time with the patient, a better patient experience, and getting the patient involved. I don't think we can punish the plan or punish the providers anymore. Let's help the patients be involved.
Mary Clarkson with the House Democratic Caucus. My question is, I believe there's also a practice transformation accelerator committee, and from this conversation, it looks like rural healthcare just slammed right up against practice transformation. And I'm wondering how closely those two groups are working together.
So there's practice transformation hub, there's several networks. And what I would say about that, and I want to really try to end this on an optimistic note, because there are some really reasons to be optimistic, and I want you all to know I love what I do, and I feel better about the future. But in practice transformation, I would say that there's, from my standpoint, kind of 3 steps that you have to have. First, you need to be motivated, and I think MAPRA admits, I think that just knowing that the data is going to be out there, you're going to compare it to your college around the state, and things like that are going to be very motivating. People get that. Then I think you need the information, and you need to understand what those systems look like, you need to have access to those webinars and stuff. But frankly, I think that information component has been way oversold. And I think that many people are really eager to show us a bunch of information, but nobody has given us additional personnel and technology or other resources.
And so not having been a part of that practice transformation accelerator, I have no idea what you just said. So apparently, though, the transformation accelerator is working on things that don't necessarily reflect the needs that were just expressed here, which is how do we adopt technology? How do we modernize in these rural clinics? We can't do it. We're just docs trying to do home. And so that's just an observation because that it doesn't sound like the two are necessarily talking at the same time.
Well, that's interesting. I started with a comment. Your observation is that I started with a comment saying that technology is a capability, rural is a problem. Right? So there are different ways to adapt solutions to the challenges that we're delivering. One is how we organize as care teams, and technology creates a different opportunity for organizing the care team. Care team organization has a period of transformation, all that was going on in Michigan or some other places. That is a separate item that you can use technology to facilitate that. So yes, we do bump into these things. but I think of it as a systemic challenge, that when we think of it as a systemic problem that has interesting problems at boundaries, which is where n is small, and where we are using technology to connect, these things are going to bump into each other. They can have positives, but I think it's a great point.
What I want to do is I want to try to summarize, because we have, the other groups are leaving, we have a little bit of a break here for the next session. And so I'm going to start looking at nonverbals and kind of thumbs up or thumbs down. But clearly, Tony talked about investing in primary care. Ralph talked about the virtual telehealth care, increasing technology, which will increase access and collaboration. One of the points that was clearly made is rural health systems. You need to use them, but they're diverse. So then we talked about, is there any chance to provide a consistency across the rural as a kind of a common element amongst all the rural delivery systems? Doug talked about the funding and financial viability, and is there a way to move from the current fee-for-service delivery system to the value-based? And everybody talked about there's a hump of retooling. There is additional money, resources that are going to need to deal with the additional expenses. And then the other, Mary just talked about linking with the practice transformation committee. But the question is, the issues there are addressing rural constraints within that. Is that committee so overwhelmed with the King County, Pierce County side of it that they don't have time or scope to deal with the rural side? Have we missed anything that we would want? Or have I totally missed the point here? Excellent.